how to plan your short-term eye mission global outreach. I know many of you have been on eye mission trips before, but some of you may not have, but you may be interested. Some of you residents after graduation may want to build this into your practice in taking a mission trip each year. So in this talk, I want to share a little bit about how to do that, some practical tips, and how to make those trips more effective. Participating in a short-term eye outreach can be very rewarding for the patient and the team. And as ophthalmologists, we have the skills needed to dramatically change a person's life. Offering vision to patients, especially to those who are truly blind, is a gift like none other. So I want to share with you the journey taken to develop and refine our eye outreaches, and in doing so, hopefully share some practical principles that can be translated to any short-term eye mission trip. I want to begin by asking some questions that should be asked by anyone considering participation in an eye outreach. So the first question to ask is, what is your purpose? I know many of you have been on short-term mission trips, but did you ever slow down to consider your real purpose in participating in that trip? Is it something worth doing? Medical missions is not a cheap endeavor. In fact, it doesn't make economic sense when you consider the total cost of delivering health care to a small group of people over a short period of time. So there are good purposes. For instance, providing needed medical care to people who otherwise would not receive it. Or how about donating your time and resources for the benefit of the local community? There are good purposes, but there are also better purposes. And I think some better purposes are when you go to provide a specialty service that's otherwise not available in that location. Or you go to train local eye care providers and you empower the local staff and clinicians to care for their own people. Most importantly, that you demonstrate humility and a willingness to be a student of that culture. Just as there are good and better purposes, there's also poor purposes that we need to remember. One is, if your purpose is to have an adventure, to see the world, to be a medical tourist, that's really not the right purpose for participating in a trip. Or how about to go and teach the natives the right way to do things? That type of attitude will not be helpful if you're participating in such a trip. Remember, I inherited a staff of 10 people who were trained by Mr. Sam Powdrell, and they were all very comfortable in doing outreaches beyond our hospital. So they, in effect, trained me and taught me some invaluable lessons during these outreaches. Here is Sam doing a tarsal plate rotation for a patient suffering from the chronic effects of trichomonas disease. Much of our ability at Tenwek to do successful eye outreaches stems from the foundation built by Sam and the early Tenwek Eye team. Well, a few years ago, I received an email followed by a phone call from another U.S.-based NGO asking if I would help them develop their cataract program. They wanted to create a program that was ready to go and easy for any interested ophthalmologist to join in and adapt easily for the outreach. Well, this is a picture of Beth, the coordinator of that program, stateside, calling me in Kenya. I don't think every conversation exhausted her, but apparently this one did. The second question you should ask is, does it make sense to design short-term eye outreaches to places that are often very rural and have little or no medical capacity? I think the answer is yes. In Africa, blindness can be a death sentence, and there's very little support. Blindness is often considered a curse or a natural part of old age, so people just accept it and often do very little to help those in their community who are blind. Question number 3, is there an unmet need for the medical services in the location that I'm planning to serve? For a cataract program, this map shows the regions of the world with the greatest prevalence of blindness. And if I go to an area to help people or to help the blind to see, but there are already eye care providers fully capable of caring for the needs in that area, I could actually hurt the community and discourage the healthcare providers that are already there if I'm not careful to partner with them. The next question is there really a need for doing cataract surgery in these areas where there's a high rate of blindness? Well, the obvious answer is yes. We all have seen this graph before and know that cataracts make up more than 50% of the causes of blindness. And a 10-minute surgery can really change a life. The next question you should ask is, can cataract surgery be done safely with good results, low complication rates, in a setting where there's little or no post-operative follow-up care? In developing countries where cataracts are more advanced, the M6 method, or manual small incision cataract surgery method, is a good, affordable technique with low complication rates, and it's perfect for this type of setting. Next question, what is the ideal minimum team size for surgical cataract outreach? In my opinion, it's about 10 people. It's great if you can have 2 surgeons, 2 scrub techs, 1 person doing biometry, 1 to 4 people running a clinic, depending on how busy it is, 1 person doing blocks before surgery, 1 running sterilization, 1 circulator, and 1 translator or patient escorter. 1 person blocking patients prior to surgery is very beneficial. Most adults who are not American can tolerate the surgery without general or any IV sedation. They simply need a local block which anesthetizes the eye. And then you need someone to run the outpatient clinic. If the clinic is really busy, it's helpful to have more than 1 person to be screening patients. And you need someone to run biometry or performing the measurements needed to determine what lens implant a patient needs. You need a person to run sterilization. This may look a bit different from the sterilization procedures that you're used to, but we'll discuss this a bit more in a minute. And then you need someone to help with patient transport. This is where it's really helpful to have someone from the local culture who can effectively communicate with the patient and ease any fears before the procedure begins. And having 1 to 2 circulators is also very nice. The next question, what equipment do you need? This is one of the more challenging parts of planning and outreach because you need to include things like a portable microscope, instrument sets, a cautery, keratometry, an A-scan, an operating cot or an operating bed, sterilizer, and possibly an anterior retractor. Well, I want to highlight 2 pieces of equipment specifically. The first is called the iMobile portable microscope. And in my opinion, it's the best in its class. It's a microscope that weighs about 30 pounds and under 50 pounds with a suitcase. It comes with a choice of optics, a large range of mobility with a top-mounted head. There's an LED light which can run all day on a small battery. There's a water bladder for ballast or weight, an optional GoPro video system with Bluetooth to monitor or to any mobile device like an iPad. These microscopes have been used by Jeff Tabin in the Himalayan Cataract Project, by the U.S. Army and the Air Force, by John Cropsey, and among other people as well. The next piece of equipment I want to highlight is called the V-Cube portable vitrectomy. The size is amazingly small. I mean, it fits in the palm of your hand and weighs only about 3 pounds. It has a cut rate of up to 2,000 cuts per minute and adjustable aspiration and infusion. There are built-in fluidics control and a traditional 3-position foot pedal with linear control. And it comes with a quiet compressor to run the pneumatic cutter. So I tested this unit in February of this year, and I actually did an entire pars planar posterior vitrectomy. And in my opinion, it functioned as good as the Alcon Acurus machine. It's an amazing piece of equipment that's just being developed, and I think ideal for mobile outreaches. Also very important in planning your eye mission is to develop a master list to include all physical equipment, disposable supplies, medicines, and team members required for a successful outreach. This is refined and improved after each outreach and adjusted depending on the expected numbers of surgeries to be done on that outreach. And then standard operating procedures can be developed to address different stages of a surgery or to address other medical problems like hypertension that will be encountered in patients on the outreach. And what about patient education? Patients need to be educated along the entire journey of the eye examination, preparation for surgery, immediate post-op care, and longer-term care. And they need to know who to call if there's a problem in post-op period. So after many months of planning, purchasing equipment, developing protocols, the NGO that I was consulted by as they began their cataract program called me and said that they have an opportunity for their first ever cataract program outreach. Well, trying to be supportive, I listened as they shared about an opportunity to do a joint outreach with Emory University and researchers from the NIH to Liberia. So the researchers from NIH were interested in examining intraocular fluids from post-Ebola survivors, but they needed a team to help perform the cataract surgeries in these patients. So I highlight this trip because it shows how a team can be made up of clinicians and researchers to provide world-class eye care while also propagating research with a global impact. As all of you know, some of our organs like the eye and the brain, the placenta, are called immune-privileged sites because of various immune tolerance mechanisms that protect the tissues from immune-mediated damage. In Ebola patients, this means that live virus can remain active in the eye for many weeks, up to 3 to 4 months after an Ebola patient systematically recovers from the illness. So in Liberia, the plan was for the Emory physicians and the NIH researchers to arrive 1 week prior to the cataract team. Now they were going to do the AC tabs from the Ebola survivor patients and do PCR testing to ensure that there was no active live virus in the eye. And then the cataract team was going to arrive and do cataract surgery on these patients, saving fluid and tissue fragments for the NIH to examine. Well, recruitment for the cataract surgery team members was unique in that it included staff from our Kenyan team at Tenwek and other nurses and support staff from North America. It's always a good idea to bring experienced team members along with newer staff to any eye mission. So having our experienced Kenya team join forces with some North American team members who were new to global eye care was a great decision in retrospect. All the team members had something to share and to teach the others. So as can be seen here for this outreach, we had team members from East Africa, West Africa, and various locations in North America. At the beginning of this talk, I discussed your purpose in participating in an eye outreach. Similar but distinct to this is the importance of setting obtainable goals for any eye outreach. Too often our goals are just to do X number of surgeries and to treat X number of patients, but we really should think much broader than this when setting goals. For this trip, our goals were much different from just doing surgery alone. Our goals included Emory University and the NIH. They successfully obtained intraocular fluids and tissues demonstrating that no live virus persisted in these Ebola survivors now, what was about 2 years from the disease onset. We also were able to operate on 22 Ebola survivors and 60 other patients with cataracts. There were no major equipment or system failures, and we provided training to the local staff in Liberia. One team member that I haven't discussed is the photographer or the story collector. Now, this person can be a very important member who spends time talking with each patient and learning about their lives and their struggles with blindness. We often have this person share stories with our team each evening to encourage them and to remind us of our purpose in coming on the trip. With the advent of smartphones and apps, you really don't need a professional photographer, although it's nice if you have one, but you really can put together photos every day to share with the team in the evening. So this is just a short example of photographs that were taken during the day on this Liberia trip, and they were put together quickly and shared with the team in the evenings. And it's very encouraging to hear stories of patients at night. It's encouraging for the team to share together. Something like this can be shared before dinner or during the team meeting at night. Now, though Liberia is a developing country with great ophthalmic needs, the facilities we were using for the clinic and surgeries were very reasonable. They were clean operating rooms with air conditioning, had stable power and clean water. So after a team gains experience in such environments, they may be willing to venture to more rural areas where the needs are still great, but the working conditions are not as comfortable. For our team in Kenya, we have made multiple trips to South Sudan, and the conditions here are quite barren. The numbers of blind people can sometimes be staggering in some of these locations, but with appropriate advertisements, people will turn up in large numbers hoping that your team will be able to help them. One challenge is learning how to treat each patient individually with dignity, offering them some type of hope, even if they do not have a problem amenable to cataract surgery. When a team is only present for a few days, I would not recommend doing complicated cases outside of your comfort zone. Rather, choose patients who have a reasonable chance of having good visual outcomes. One of the things that we've learned from the Liberia outreaches was the importance of having someone on the ground screening patients ahead of the team's arrival, if at all possible. For this trip, we had a New Zealand physician couple, non-ophthalmologist, and their mother, who was also a physician, who served full-time in this location. We had them screened for several months prior to our arrival. This was a tremendous help to our team. This partnership between the short-term team coming to provide services and the longer-term team on the ground is key to any successful outreach. Not only does it enable a more efficient outreach for the team coming, but it enhances the permanent health facility on the ground, providing long-lasting impact. Now, what about sterilization? Some environments where your team may travel may not have the sterilizing equipment or capability that you're used to. And while it's important not to compromise with sterility, adjustments can be made that still enable excellent care despite limited resources. So in South Sudan, this meant boiling water over charcoal to sterilize our instruments. And because the temperatures could be 100 plus degrees, wearing full gowns was not practical. Here you see us operating in short-sleeved shirts, but we maintain sterile hands and a sterile field for the procedure. Remember the role of the photographer or the story collector? There are so many human impact stories that you will miss without someone in this role. For instance, this is a lady who, prior to cataract surgery, had been blind for more than 5 years. She has two sons, this one being the youngest, 10 years old. This youngest son has been helping her with all of the farming and the cooking. And when asked if her son looks any different than she remembers 5 years ago, she responded, "He looks much thinner, probably from all the cooking and farming that he's been doing for me. When we get home, I'm going to make him healthy again. I will be the one taking care of my household again. Because of God, there is no fear. If he can bless me like this with my eyesight, he can surely bless me again. I'm not going to depend on my walking stick again." So these types of surgeries or stories are very encouraging and worth sharing with the team each evening. Now this is Sabet. He's the one on the ground who oversees a small medical clinic and community development projects in this area of South Sudan. He's not an ophthalmologist, but if our team works well together to deliver quality eye care, it enhances the other programs that he's running on the ground. So quality eye care delivery in even these rural, desolate environments is quite important. Sorry.
Hold it still. He's counting.
So be prepared for some cultural reactions to restored vision that may be different from what you're used to. This was a short clip of patients in South Sudan from the Dinka tribe after having their patches removed from cataract surgery. So in summary, ensure that your purpose for going on a trip is good. Evaluate the medical needs and whether there are adequate healthcare providers already present to meet those needs. Thirdly, ask the question, will the team be helping, not hurting a community by offering its skills and expertise? Can the team perform safe surgery and ensure reasonably good post-operative care? And finally, remember, record those patient stories to encourage the team and those supporting from back home. Thank you very much.